my pleasure to introduce Professor Carolyn Graham. And like Imran said, she has been a great friend of Pakistan. Carolyn is a GP principal in Central Manchester. She's Professor of General Practice Research at Keele University. She, while at the same time, is Honorary Professor of Primary Care Mental Health at Midlands Partnership Foundation Trust, an Honorary Professor of Primary Care, University of Manchester, and Visiting Professor at the University of York. Carolyn's main area of interest and expertise include the primary care management of people with mental health problems. We all know it's a huge issue with regard to mental health difficulties presenting to primary care, including people with multiple health conditions and unexplained symptoms, and the mental health and well-being of clinicians. It's particularly important at this time of COVID. She has qualitative research methods expertise, drawing on theories from social sciences and psychology, but always with a focus on clinical practice. And that's very important when even people talk about culture sensitivity and culture competence. How can you support that it moves on to clinical practice? She tries to answer questions that are important to patients, their families, healthcare professionals, and the NHS. Carolyn chairs the RCGP Research Paper of the Year panel, and she is also the Curriculum Advisor Mental Health. She's chair of the Society of Academic Primary Care. Carolyn is currently a member of the NICE Clinical Guideline Development Group, Depression Update, and a standing member of a NICE Quality Standards Advisory Group, work which directly impacts on commissioning decisions and patient care. Carolyn, it's to you now.
That's great. Thank you very much, Nusrat. Okay, so Samin, I think you're sharing my slides, is that right? So I'm afraid you're going to have to hear the next slide, please, quite frequently. Thanks again, Nusrat, for inviting me to speak today. Hello, everybody. You will notice that I've got lockdown hair, so I'm very different from the photograph that was put up. Thanks, Imran, for the introduction, and you've done quite a lot of the work I was going to do. So I'm sorry if there's any repetition, but hopefully it will be reinforcing important messages. So I'm going to talk about the qualitative work within the CPAP study, the CPAP trial that Imran mentioned. And this is culturally adapted, manual assisted, problem solving intervention for self-harm. And as Imran said, this is funded by the Medical Research Council. Next slide, please. Imran's already said this. Suicide is a serious global public health problem, ranked amongst the leading causes of death in the world. And we know that 75% of suicides occur in low and middle income countries. And as Imran's already said, the World Health Organization Mental Health Action Plan is committed towards at least a 10% reduction in suicide by this year. Next slide, please. We also know that self-harm is a risk factor for suicide, and therefore offering appropriate interventions to individuals presenting after self-harm should be a key component of suicide prevention strategies. And at the time the CMAP intervention and trial was being developed, there were more than 100,000 episodes of self-harm annually. Again, as Imran's already said, suicide and attempted suicide used to be classified as illegal acts. They still remain socially and religiously condemned. Next slide, please. So I'm going to present the first qualitative study that was done as part of the CMAP trial work. And this is about clinicians' perspectives on barriers to access to care for self-harm in Pakistan. The team obtained ethical approval, and we recruited hospital physicians working in the medical units of public hospitals that were already participating in the CMAP trial, and GPs or family physicians working in practices located in the locality of hospitals participating in the CMAP trial. And we asked them to participate in a single semi-structured interview. We obtained written consent and the interviews were audio recorded with consent. Next slide, please. And our topic guide, which was developed by the research team with reference to previous work and with reference to the literature. So we explored understanding of the term self-harm. We explored participants' perceptions about reasons for self-harm, and particularly what the current pathways for care were and how people with self-harm behaviour were managed. And as with all qualitative studies, we modified and refined our topic guide in the light of our interim analysis and the themes that we were developing. The interviews were conducted and then transcribed verbatim in Urdu. They were transcribed into English and then back translated. And we continued interviewing until data saturation was achieved. We adopted both an inductive and thematic interpretive approach, and analysis was through discussion within the team, and this was all done virtually. Next slide, please. And I'm going to present the findings of interviews from 7 GPs, 3 of whom were female, and 11 hospital clinicians, 7 of whom were female. And I'm going to present the 4 main themes today. Next slide, please. So our participants talked about what they perceived the motivators for self-harm were. They talked about this self-harm being an attention-seeking behaviour, to make their family members scared, to seek attention, to convince someone of their distress. Participants talked about the different ways that people may harm themselves, and a number of the GPs particularly noted a gender difference. So females may overdose, but described self-harm or attempted suicide using more serious measures such as gunshot. A number of our hospital physicians talked about self-harm and suicide only being related to severe and enduring mental health problems like schizophrenia, and not really linking self-harm to distress, depression, anxiety, or a reaction to family circumstances. So, the participants all talked about the various challenges that they encountered when managing people with self-harm. So when the interviews were conducted, suicide and self-harm were illegal. And so some of our participants talked about the need to have a medical certificate, that they needed to inform the police if somebody had either carried out self-harm behaviour or attempted suicide. And this was a challenge because patients perhaps wouldn't want this to happen, would therefore not present for care, present late. They talked about how families would try and hide the self-harm or suicide event. And because of that, again, presenting late. But our study participants also talked about the fact that even if they've got over those barriers, they actually don't have the correct services in place to provide support for people, psychological support for people with self-harm behaviour. Next slide, please. And they talked about further barriers to accessing care. So stigma was something that ran through many of the interviews. People were afraid that what will happen if others come to know we visited a psychiatry department because our family member has committed self-harm. They talked about how public, so people in their community, could misuse information. They talked about being worried that families were worried that they may be blackmailed because of this sort of event happening. Healthcare professionals in our study said that people who self-harm are perceived as not being normal by their family and by their society in which they live. And again, this GP1 says that really only 50% get proper counselling. Others may seek help and support from religion or spiritual support, and suggested that those people were in denial state, not seeking proper help. Next slide, please. So we asked our participants what they thought the ideal care pathway should be for people who've got self-harm behaviour or following a self-harm episode. And GP5 says, in our culture, we do not teach problem-solving strategies, but that is necessary for them. If we taught them about problems and how to solve their problems, they would realise that their existence in the environment and learn to solve them. So this GP was saying that problem solving might be an intervention that would help people and prevent self-harm because they would have appropriate strategies in place not to respond to distress by harming themselves. And all the clinicians that we spoke to said it's really important to have a multidisciplinary approach. We need some psychological support. We need to address financial problems. Next slide, please. So the implications of our study, our qualitative study with clinicians, was that we feel that it's really important to understand clinicians' views on self-harm, because these are people who are working with patients presenting with self-harm on a day-to-day basis. It's important to understand the broader socio-cultural context. This is around making any intervention culturally competent or culturally sensitive. We think that public health initiatives should ensure the importance of mental health and illness. And we need to afford equal status to mental and physical health, because all our participants identified that mental health problems were not well dealt with. And we feel that there's perhaps a need for training of doctors in the identification and management of people with mental health problems, including the management of people who self-harm. Next slide, please. So that study was conducted at the start of the CMAP trial, which Imran's already spoken about. And an impressive 901 people were randomised. Next slide, please. So Imran and Nusrat asked me just to mention the CMAP intervention. This was a 6-session intervention carried out either weekly or 2 weekly. And the sessions covered getting started, establishing a relationship with a study participant, explaining what to do, what was going to happen in the intervention. The second session is about responding to a crisis, responding when an individual feels distressed. What can you do instead of harming? There was a session on problem solving and a session on changing thinking or reframing how distress is perceived and what the responses to distress might be. There was a session on keeping well, identifying when perhaps you might be getting distressed and what to do about it. And finally, there was a family session, because it was recognised that actually the family are key to self-harm and support for people with self-harm. So we had 20 wellbeing practitioners or therapists, and the therapist training took place over 2 weeks, but there was regular supervision and also top-up training. Next slide, please. And within the CMAP trial, we conducted a second qualitative study. And in this, we wanted to explore patients' and therapists' perspectives on and their experiences of the CMAP intervention. Again, ethics approvals. We invited patients who'd completed the CMAP intervention to participate in a semi-structured interview. We asked all therapists if they'd participate in an interview, and we recorded the interviews and transcribed them verbatim. Next slide, please, sorry. And again, our topic guides covered the people's understanding of the term self-harm and tried to explore people's reasons for self-harm. For the CMAP participants, the patients, we attempted to understand their experiences of the CMAP intervention and whether they found it acceptable. For the therapists, we wanted to explore their experiences of delivering the CMAP intervention, their experiences of training and supervision. And again, we modified our topic guides as analysis progressed. As before, we conducted and transcribed our interviews in Urdu, translated to English and back translated. And we continued until data saturation was achieved in the 2 data sets separately. So we analysed each data set separately, followed by comparisons across the data set. Next slide, please. So we conducted 40 interviews, 20 were study participants, 8 were female. And I think it's important to say that these 20 participants, the gender mix was quite representative of the CMAP participants. So I think that Nusrat and Imran running the trial were pleased that actually males were enrolled into the trial, not just females, where we always associate self-harm with the females. And we interviewed all 20 therapists, 15 of whom were female. The themes I'm going to present today are, self-harm as an impulsive act, precipitants of self-harm, perceptions of impact of the CMAP intervention, challenges in delivery, and people's suggestions about how we might improve the CMAP intervention. Next slide, please. So for both patients and therapists, self-harm was seen as an impulsive act. Something happened in the person's life that made them distressed, and their response was self-harm behaviour. So 2 patients here. One said there was a fight going on, a little fight going on at home with my mother-in-law. The fight was because of money. That's why I drank bleach. And patient participant 15 says, I was not in senses. When I'm angry, I lose my senses. Don't know whether I'm doing right or wrong. So a sense from participant 15 that really unsure of what to do in response to distress, and therefore the response is self-harm. Next slide, please. Precipitants of self-harm very much mirror what our clinicians said. So lack of support. As participant 9 says, if I was happily married, if my husband was supported, then I would never have self-harmed myself. And therapists talked about abnormal coping. So a response to stress is hurting themselves or self-harm behaviour. So you can see that our intervention, our CMAP intervention, responding to getting people to understand how they respond to distress and changing that is likely to be helpful. So moving on to acceptability of the CMAP intervention. Participant 15 said, I want to say how very thankful of the therapists. They spend their time to make us understand. And most of the patient participants talked about how being understood, being listened to, having time spent was really important. Importantly as well was the acceptability of the CMAP intervention to families. So participant 3 says, in the morning my mother said to me that you have to go for the session, as she was seeing changes in me. And that family support and that family encouragement to attend is really key. And the therapist felt that this intervention was acceptable to the people they were working with. It's very good, patients do cooperate, they feel better, they provide us with feedback. Next slide, please. And did CMAP impact on people, and how? So participant 8 says, well, now when stressful thoughts come into my head, I can handle them. I can characterise them as wrong or as unhealthy thoughts. So a number of our participants said they could, because of the CMAP intervention, they could deal with the distress, they could deal with the unhelpful thoughts, and they were dealing with it in a much better way. They were not harming themselves. All the participants talked about the problem-solving session as being absolutely essential and a key session for them. So participant 11 talks about, I learned stitching. Now I'm doing stitching and earning money, and time's passing because of it. So being distracted from the distress, but also doing something useful. And the therapists highlighted the problem solving, but also the learning distraction techniques and overcoming unhelpful thinking styles as being effective strategies that they were using. Next slide, please. All the patients and the therapists talked about the challenges that there were in actually either receiving or delivering the intervention. And some of those challenges were around members of the family, caregivers, spouses. So participant 17 says, initially my husband stopped me, And I explained to him in detail, now he's okay with it. So we saw that participants had to get the support of their family to participate in the CMAP intervention. One therapist, therapist 3, says there were a number of patients whose families didn't want them to come. And he says that there were also some cases where they didn't do the family session. So therapists talked about a spectrum of experiences, some where families were involved and actually perhaps involved in a number of sessions, but to the extreme where some members of the family would not participate in the family session at all. But many described how the views of the family were key to whether a person engaged and carried on with the sessions. And therapist 20 describes what sounds like a really challenging session where a female was asked to leave in the middle of her session because her husband had called her home. And then they had to move to delivering the sessions at home, which was challenging because of the husband's request. Next slide, please. So moving forwards, how should we change the CMAP intervention to perhaps make it more acceptable, to make it able to be rolled out? So one patient talks about the gap between sessions being too long. He'd had 2 weeks between sessions, and he says it can cause the mind to wonder. Mine didn't, but there are some emotional people. So, don't give long gaps between the sessions. Most of the therapists said, really 6 sessions isn't enough. I feel there should be more. Patients wanted more. So there's a question about balancing the number of sessions that are effective, that we can afford, and the number of sessions that perhaps would be acceptable and wanted by patients. And then a key challenge going forward is the family. One or 2 therapists said actually we should hold sessions with the family early on to get them engaged in the intervention, to get them working with the study participants, because they are key. Next slide, please. So the implications of the second qualitative study: we feel that the CMAP intervention is acceptable to people following an episode of self-harm, and particularly may help people develop problem-solving skills. We hope that the intervention's got a role in the prevention of self-harm and therefore suicide, and we're continuing to analyse our data to explore the barriers and enablers which will help us think about how to implement this intervention in the healthcare system in Pakistan. Next slide, please. So Imran's already mentioned this. I've labelled the slide Contact in High Places. The interim findings of the study, particularly the qualitative work, was presented at the All-Parliamentary Pakistan Mental Health Summit just before lockdown. So this was a very memorable experience for those people who were lucky enough to attend. Next slide, please. And oh, my slide has been changed around. Anyway, capacity building. I think one of the big things about this is that we've Penny B and myself worked at a distance, so a lot of our work was done by Zoom or Skype or telephone and email, and we feel that we did a reasonably good job of the analysis without the need for face-to-face meetings and post-it notes helping us with our analysis. We've got one paper which has been submitted and one paper that we're preparing. We hope that we've contributed to capacity building in terms of qualitative research skills within our team. Next slide, please. And just to acknowledge that team, so Naseem Chowdhury, who's speaking next, I think, after the break, Penny B from Manchester, Tayeba Sarish, Sana, Anna, Afsan and Nusrat, of course. I think it's been a great team to work in, and I hope we can do some more work together once we get our papers sorted. And I think that's the last slide. Oh, I think there might be one more slide that's got my contact details on. Yeah, I've left time for questions, so happy to answer any.
Professor.
Thank you very much, Carolyn. Excellent talk. And I have a question, but before that, can I find out from Samin? Samin, are there any questions in the chat, or otherwise I'll ask questions?
Let me have a look, sir. So we have comments, and in problem management plus PST, it's Mr. Did you have issues with recruitment given the stigma surrounding self-harm suicide?
So I'm going to see Taiba, I think, is on the call. Is Taiba there?
She's there.
So would Taiba or Naseem like to respond to that around recruitment? Because you actually did all the hard work.
Or maybe Imran can do that about recruitment and retention.
I'm happy to volunteer, Daiva, but I'll try. Okay. So I think we were for the larger study. It's the network of the team. It's relentless visits to the community clinics, to outpatients, to emergency rooms of various different government hospitals, keeping regular contacts, getting lists, updates on a virtually weekly basis, daily basis, weekly basis, on regular intervals about the number of emergencies that have turned up. So, sorry. And, you want to add something? Go ahead.
No, I'll leave.
Okay. So, purely dedication of the team, and then retention. Again, I think it's the quality of work, the links they have developed, the relationships that formed, the contacts, the empathy, the warmth. It's all part and parcel of it. And hence, to keep this difficult set of people who are literally, remember the stigma and the shame. So it's not a normal clinical intervention study where they're glad to share people. It's not like a COVID vaccine that you're giving that people will take it like cherry. No, this is people really wanting to shy away from this. So this purely has to go with and to be fair to people who trained the team. These seniors, the supervisions they were having, they all played a part in it.
Okay, thank you.
Yeah.
Carolyn, you are saying something?
So I was just going to say, we did struggle to recruit the sort of GPs or family physicians, and I'm not sure whether Taiba or Naseem can remind me why that was the case, but I think we only got 7 in the end, whereas I think recruiting our hospital physicians was much easier.
Naseem, can you comment on the GP's recruitment? You are on mute.
Yeah, I think, Caroline, it is because a lot of these GPs are very busy private practices, and for them to find that time for the interview, I think that's the basic. But hospital physicians, because they were working in hospitals, we could easily arrange times with them. So basically the struggle was that they mostly would say that we've got such busy practices, and it was the time constraint for those GPs.
Can I add to it? I think since then we have been able to develop more relationships with the GPs now. So we've also learned quite a lot of how to work around GPs. And Carolyn, you know about is not hugely different from the UK, but I'll take the chair as prerogative and ask a question to Carolyn. As you've worked with the British South Asian population on self-harm, and your practice also has a very diverse population. Could you say something on the differences or similarities between South Asians here in the UK and what you saw in Pakistan? I can't hear Carolyn. Samin?
So
Yeah, got it. Yeah, you're there,
yeah,
Carolyn.
sorry, Samin had muted me and it wouldn't let me unmute. I think that's a really broad question. So if I put my clinical hat on, then I work in central Manchester in Chorlton, and our population tend to be, we have some older adults who perhaps don't speak English particularly well, but are supported by their families. But then we have second and third generation South Asians who don't have language problems, may have adapted and embraced the sort of Western idea of distress and depression and stress. So I don't think we have the same barriers that maybe there were 20 years ago where the language was different. Having said that, I'm supervising a PhD student who's looking at distress in adults with long-term conditions, and he's conducted a systematic review and is starting some qualitative work, and actually we are finding when people talk in an interview situation that they are talking about spirits and not having a language for depression and not really going for the Western model of depression and stress. So I think it's interesting that in a research situation, when somebody has an hour's interview, they can talk about what's really going on. When they perhaps come to the GP in Manchester, my experience is that they're much more willing in that 10-15 minute consultation to adopt a Western approach. And that may be because that's what they think will get them some treatment. I mean, in terms of what the sort of attitudes that we saw in the interviews, people's perspectives of self-harm, I think they were actually very similar. So the stigma was there, the shame, the response to distress was similar to what we see in the West. But I think the fact when we started CMAPs, self-harm and suicide was illegal. I think that was a big barrier to recruitment to start with for both practitioners and then patients for the study. But their unwillingness to talk about it and their fear that if family knew about it and if the rest of their community knew about it, it was a black mark against them. It was going to affect their marriageability. So we've got a lot of really rich data about fear of it getting out that they've harmed themselves.
Thank you very much. There's some more questions, but we'll have to take it or respond on the chat. Thank you.